Welcome, everyone. Good evening. Good evening, Natalia. She wrote good evening. Welcome to Mondays with the Midwives. My name is Kirsten Olson, and I have been working at VCU Health for going on 8 years, my 8th year. And I was hired doing group prenatal care, and that's still what I do. I run the program for group prenatal care, and I love it. It's really fun. I love pregnant people, and I love babies, and I love new families. So that's what I love to do. We're going to be talking today with Hagi Volde Johannes. She's one of our midwives, and we're going to be talking about Black maternal health. And we're going to have a little conversation, but then if you do, if you want to go ahead and just chat questions in there, we definitely want to carve out some time at the end to answer questions. So absolutely, we'll do that. But Hagi, would you like to introduce yourself? I know I have one question for you, that I know that you came from a public health background. So if you could talk a little bit about that, and then moving into midwifery practice.
Sure. Okay. Well, hello, everyone. Greetings. My name's Hagrenesh. Like she said, Hagi is my nickname. And so I'm a midwife here at VCU. I started in October. I'm a newly licensed nurse midwife, but I've been running with midwives for the last 15 years, I'd say, in different roles and trainings and growing as a woman and a caregiver in the meantime. So I did come from public health. I think I started actually in medical anthropology, which is kind of, I think the big story is I started from a broad lens and have focused in. And so that's kind of the background. So I came in through medical anthropology. And at that time, I was looking at the social stigma with HIV/AIDS and how it was affecting my people. I'm Ethiopian, and then also the people around me in Oakland, and looking at how we understand healing in healthcare and what we'll allow for ourselves and our bodies, how it integrates with our belief systems. And that kind of led me to like the work that I was doing around organizing and traveling, doing a lot of things in Ethiopia. And I came back, got a master's in public health, like this is what it's going to be for me. Got to travel a lot, family planning, youth reproductive health access, proper education, helping to write policies. Again, from this broader scope of like, we should all have access. We have basic human rights. We have the right to conceive. We have the right to decide if we want to conceive. We have the right to not have other people enforce onto our bodies, power over our bodies as women, even as young people. So I did that work, always was working with midwives, women's health care practitioners, always knew it's what I wanted to do, but it just kind of was a timing thing. And then switched over in 2006 to really pursuing my dream. And so that's why I said it's kind of been a journey for me, because I trained with home birth midwives. I'm a nurse. I did med-surg nursing, NICU nursing, postpartum nursing. I was a postpartum nurse for a birth center. I would do home visits, like hour, 2-hour home visits. I led a program looking at environmental health disparities and prenatal outcomes for Black women in Atlanta. We have the highest rate of exposure to environmental toxicants, and that's usually from our beauty products and the things that we eat and the things we store our food in. So I led the front on translating that research into practice. So my public health was really always around women and children and family health. And it was a natural progression for me personally to just get closer and deeper and closer and deeper. And midwifery has been that. It's a calling, I feel. And so here I am, and I have 3 kids. So I've had my own birth experiences on this road. And so, yeah, I know I answer these questions kind of windy, but that's my story. Oh,
no, I think it's interesting. And I think that's kind of, I guess that was one thing to sort of clarify or kind of point on is that you kind of talked about how you kind of were circling closer and closer and closer to midwifery is kind of like, okay, this is kind of that like an epicenter or something. And so I was kind of wondering, were you seeing anything in particular in your public health work around Black maternal health that kind of kind of led you to think, maybe I think midwifery is where I would be best suited and best positioned to do the best kind of work that you were kind of seeing in that public health realm?
Yeah, for sure. I mean, personally, I'm a Black person in this world. And so there are things that I've understood from my own interactions with the greater healthcare system, interpersonally with providers, the assumptions that have been made about me, assumptions that have been made about my immigrant family. So I had that, my own understanding of the greater system. And then as somebody trained, I also was able to kind of identify because I came into it as already an adult, having worked all over, in sub-Saharan Africa, all over this country. I've lived in like all major regions of this country. So being able to be like, oh, this is why like someone could look at me and decide that these are risk factors that I have. This is why a person might assume that I was late because I caught a bus and not because of this or that. Like assumptions about the dynamics that were a part of my life without asking me, assumptions about the things I was bringing in or how committed I was to my healthcare. Those kind of things, I lived them. And then being trained in a system, that pumps out providers and that trains us really to deal with problems like acute problems and identify symptomology and understand risk factors, which is important and effective, but the nuance gets lost. The
Mhm.
cultural humility, sometimes the language to like lean into curiosity because you don't know what's going on with somebody. I could see how that was getting lost in my training. I was thinking about, whoa, just being Black, does that mean you're at risk for, you know what I mean? Hypertension off the bat, diabetes off the bat. Yes, statistically, we understand why we think that, but then I'm going to look, what's going on with you? What are you eating? How did your mom feed you? What's going on in your household? What's your stress level? You know what I mean? Under kind
Mhm.
of having all of that. So I think that seeing that there was this disconnect, like, cultural incongruence with the way people were feeling about their expectations for healthcare and the level of connection that was expected when people came in, and then the level of expectation on healthcare providers for how much they should give. That I could see that thing, and then I'm like, oh, I want to be different, and I'm generalizing because there are amazing providers
Oh,
all
yeah.
over. Yeah,
Yeah.
it's just about this like these bigger systems of like we want to be able to have these broad statements that we can apply and use and stand on like ladders, so we can look over the top like I understand this field of knowledge. I got this. But really in human care, like it's kind of this seesawing, this kind of wavelength of like how real and centered are you in your life? You as a person, and what kind of energy do you bring into this room, and do you have the expertise and the curiosity to really explore? And I think that's what we're missing as Black women in our healthcare, because there's the historic and systematic way that we've been at the bottom of this totem pole, in terms of value,
Mhm.
like societal value. And so then you see how, a person could be coming in good natured and they're trained well, and maybe they're young, maybe they don't have experience, maybe they do. And they're like, oh, you're in pain. Okay, I'll get right to it. I'll be right with you. But not like this, like the way we interpret things from Black women, this medical, like this lens that we have, we can see it in the ways that we're trained, in the ways that society tells us what's okay, what's not okay. And we see it on both sides, from the provider and from the patient, And so I just wanted to be a part of like shifting culture because I could feel it all. Like I can feel all of that as a woman, as a daughter, as a wife, as a mother, like as a provider, as a nurse, as a public health professional. Like I feel very privileged that I've been able to wear all these hats. Sometimes it's hard for me to articulate it succinctly because it just feels like this contextual kind of sunglass that I wear. And I'm like, oh, I don't, something, what are we missing here? What can we
Right.
do better here? What do you need from me right now? You know?
Well, and I think that's one of those things. I think what you're talking about too is that there's that idea of like the implicit bias and racial bias, right? And so everybody has these biases, but when you're kind of trained up through a system that has a sort of specific hierarchy, like that patient or the physician provider patient relationship, and that implicit biases are often cited as being used more readily, more easily when you're kind of under stress. So like when you're in the hospital or when you're in a really busy clinic. And so you just kind of, it's like a lazy slide into these implicit biases. And then, yeah. And what those biases also do is create these barriers to a real human connection. And I think that's kind of interesting, like what you're talking about too, on from your personal point of view, is you're able to, at this point in your career as a midwife, you're kind of able to cobble all of these lenses together, right? Kind of like this more kaleidoscopic view that's not just sort of like this medical model that you've been trained up through, but you also have this public health model. Plus you have this real like, hey, I have a unique experience of like immigrating to this country and like being a person of color and, and how to navigate all of that. And then so you're kind of putting all of that into how you deliver care to people, that you're actually like, from what I hear from you is like, you're here to serve women, not to kind of come in and lecture to them and make assumptions about them and the way they live their lives. Like it's more like, okay, tell me who you are. Like, let's get to know each other
Yeah,
first. And then we kind of work on a plan
sure.
together.
For sure. Yeah. And I mean, I don't think I'm perfect or that I'm a new provider. There's lots for me to learn. But I think, yeah, on the interpersonal level, I really care. And I want to know exactly like you said, like my approach is that, like, what do especially in pregnancy and birth. And like that's part of why the specificity around the Black maternal health crisis, whereas like this is a really vulnerable time, you know what I mean, for women, and that
Mhm.
it's a primal process where we need to feel safe and secure, where there needs to be trust established and there needs to be care, right? And so that's different than your appendix may have burst, or like you're on the verge of some emergent situation. That's a time when you really do have to move at a quick pace. You need to identify what's going on, you need to treat, you need to move. With pregnancy, because it's a normal physiologic process, for many of us, especially our first time, it's super new, we're not sure. It's hard to shift out of control into surrender. That is a process. And so that's another piece to this that I think makes us as midwives different, because we're looking at you holistically and we're trying to meet you where you are to empower you to do this thing, excuse me, that we believe that you can do, that you may not believe that you can do, or that maybe you have misinformation, or maybe there are gaps in your information, or there are tools that you need or resources we can provide you. So that's an important I got distracted. That's another important part of this conversation, that's midwives, that's our specialty. That's a piece that's kind of unknown for people who don't understand. They're like, oh, I'm pregnant now, what do I do? That's the
Mhm.
difference, is that we really are working with low risk women. Here at VCU, it's awesome because we can collaborate with physicians. We can have people with us that may have comorbidities, chronic illness. They may have risked out of like another midwifery service, but because we have the OBs and the MFMs right outside our door, we're able to do that collaboration where we're treating you as a low risk person unless there's a situation, right? But that holistic wraparound care, that's something that I think that's inherent to like the culture, many Black cultures, many of us, all cultures, all women. But I would say if we're talking about what's lacking, it's kind of this emphasis and value on trust. And trust is something that takes time, and there are
Mhm.
signifiers of that. You know what I mean? That's like a relationship building that is different than other spaces that we receive healthcare in, most of
Right.
us.
Well,
Yeah.
so I have a question. There's a quote I want to read you. So I'm sure a lot of people know about Dr. Ibram Kendi. He did write the How to Be an Anti-Racist, but he also wrote Stamped from the Beginning, which is this amazing. It's like this thick. It's amazing. Stamped from the Beginning. If you haven't read it, you should read it. But anyway, this is a quote from him. If we truly believe that all humans are equal, then disparity in condition can only be the result of systemic discrimination. And so I know we want to talk a little bit about, because we kind of, everybody knows the statistics, like we get that data reported on all the time, that BIPOC folk are 3 to 4 times more likely to experience maternal mortality, infant mortality, preterm birth, all these things. And so it's kind of like, okay, so what are some of the tools? How do we get to this? Do you think that the midwifery model of care is a tool and a robust tool and a robust anti-racist tool? Can it be leveraged to be an anti-racist tool within the healthcare system that has been called out for being racist? Oh, kitty.
Oh, cat's like, yeah, I can.
I believe it.
Okay, all right, kitty. Yeah, I believe that absolutely. Like midwifery can be that, because this is a primal process, like the delivery, physiologic birth. It's bigger than any particular. Is that your cat trying to get in the camera now?
That's my
Oh,
my daughter trying to get the cat out of the room. Thank you,
okay,
Maddie.
okay.
Working from home.
um, yeah, right. Um, yeah,
So yeah,
absolutely.
so can midwifery be sort of leveraged to be a more productive, like robust anti-racist tool in healthcare?
Yes, absolutely. I mean, embedded in the midwifery model is this wraparound holistic service idea where we're sitting with you. Our prenatals are often, they're longer, they're deeper. We go into places. Many of us as midwives have kind of explored, folks are spiritualists, they're herbalists, there's all these interests in like natural care, in food and diet, to not just the general, but like how do we heal ourselves with whole foods? What are the options out there? Pelvic health? Why should you care? I don't know. It just like there's so much nuance to all of our stories, and even as midwives, we as women, as midwives, we bring that to our patients. Like, okay, where can I meet you? What is it that you need? And it's this. I think it can be anti-racist because it's beyond just kind of the skin that you're in. You know what I mean?
Hmm.
It's about this human experience, and that level of connection. We all desire that, especially when we're scared or we're unsure, or we want to have information and we know we're standing in a gray space, but we want to feel like we're making solid steps forward. That type of relationship, the kind you can build with your midwife, becomes even more important then, because you have a provider who is like listening. And I'm not saying doctors don't do that or other people don't do that. I'm just saying that's embedded in our model of care. Like
Right.
that's
In
the
your
way that we're
training too,
trained.
like that's as you're kind
Yeah.
of coming through nursing school is much more of like a humanist lens. And then midwifery is
Yes.
still kind of like really grounded in social constructivism and humanism, right? Like how to relate to human
Yes.
beings.
Yes. And human rights is like
Hmm.
the foundation of all of that. Like to relate to it one another, we need to respect each other's rights. And that's midwives across the board. For many of us, it's a calling. And so whether you're a nurse midwife or you hold a different type of license or are trained in a different traditional model, still that midwifery model really honors a woman and her process, anyone with the uterus and their process. And what do they need to get to the other side? Because that vulnerability, it's not just a switch that you just flick on. You
Right.
know that.
Yeah.
It's a process. It's a process.
And I think
Yeah.
too, and this was something because we did a conversation, I think it was like 2 months ago with Megan Noonan, who's another one of the midwives, kind of talking about how midwives can carry you in your care throughout your lifespan. So I think
Hmm.
that's kind of important to kind of think about too, especially when we're talking about Black maternal health, just like Black person with the uterus health, right? Like because it can carry you. It doesn't have to just be that you create this really great relationship with somebody, but you only get to see them when you're pregnant, or postpartum. And that's not actually true. You can actually keep
Yes.
that,
Oh yeah.
keep that really strong relationship throughout across your lifespan.
Yeah. I mean, I know for Leslie's been a midwife, I don't know, over 20, 25 years. So she's taking care of folks like through pregnancy, through postpartum, through menopause. I think that she has patients that she took care
Mhm.
of their mothers. And you see that intergenerational thing with a lot of midwives and midwife care. For me, I've taken care of I think my youngest patient I've seen is 18 years old. So she's not, she's coming to me for her annual exam. She's not able, by guidelines, we're not giving her a PAP, but we're talking about it. We're talking about what is reproductive health and how can she be safe, and what are the options, and then of course folks that are interested in getting pregnant, preconception. We want to talk about how do we set you up for that? How do we set up for success? What kind of medical history do you bring to this? What are the supplements you can take? What is the diet? What's the mindset? How are you
Mm.
exercising? How do you prepare for this? And we have our pregnant mamas, we have our postpartum mamas who've delivered with us that will still page on-call midwife with things going on with mood lability or feeling like you need access to certain resources, or pelvic pain, needing a referral. And then of course just the reproductive years of just like the birth control, or just wanting to make good decisions around your reproductive health,
Right.
having an itch, having a burn, having a
Right.
UTI. Like, we get it through the portal. People come in for their annuals, people call us for appointments,
Yeah.
and
And there's
through
like nothing like
menopause.
having like somebody you can rely on them, and they're not gonna
Yes,
you don't have to explain who you are all over again. It's just kind of like there's like this immediate relationship, and then like yeah, and kind of just
it
feeling
feels
like,
like
ah,
community.
yeah, like I
Yeah, and
don't
that
have to go
community.
in. Yeah, I don't have to go in any other kind of way but just who I am, like
Yeah,
you don't
sure.
have to worry about like code switching so much and things. Like you don't have to worry about being judged by the color of your skin, or kind of going back to that, like those assumptions that people make about like because we were talking about how women, all women, not just but like when you're afraid, it's sometimes, I think a lot of times what happens is when what I've seen with women of color, if they're anxious or afraid about something, um people kind of write them off as being like angry and upset, and oh, she's hard to talk to or whatever. Like she's scared. Can't you see that she's anxious about something? Like she has questions. So I don't know.
You're talking about patients or just
Yeah, just
you're
patience.
saying?
And I think it's just so nice for a patient to have a place to go where it's safe.
Yeah, we all need community and we all need that congruence. And whether for you, I mean, I think it's difficult as if you're not a person of color to understand how deep imposter syndrome, or the feeling that you don't belong in a space, or the idea that you have to present a certain way in order to be received in a way that's safe and like conducive to your needs. Like, that's a lot of weight. That's a lot of feeling to bring into an interaction. And so I think that we all need that sense of community and that sense of belonging and connectedness. And it feels like concierge to be able to just hit up your midwife, like, I'm feeling this. Can I get on your schedule? Or can I call? Like, you feel like you have support. And that support is really important, especially for those of us who are not getting it in our greater worlds. You know what I
Right.
mean? In our everyday interactions that are having to like wear different faces or present different ways. And it's not like you ever escape it. You know what I mean? It's not about your level of education. I know even for me, like with all the different identities that I hold, I still am not able to always express my true self in certain environments. Like that takes time for me. You know what I mean? And that I'm not unique in that, but I'm just saying that like we want to hold you as midwives. We want to be with you through the journey of your reproductive years, but especially during childbirth. Because when we talk about this Black maternal health crisis, a lot of it just goes from simply like, listen to Black women, trust Black women. Like, folks deserve. I have like the Birth Justice Bill of Rights in front of me. I have a bunch of different like resources that you can find online. But I know from Black Mamas Matter Alliance, when we talk about holistic care for Black women, we talk about it being confidential, safe, trauma informed, affordable, accessible, that it addresses gaps in continuity. This is simple stuff. Like, this is stuff that we're all trained in, but we don't always lean into, especially
Mm.
structurally. You can want whatever you want personally, but you're so busy too as a provider. You're like running on this machine the treadmill's going fast, and you're like, oh, I want to be better, I want to do better. But we rely on these structures. And so these structures really need to address these gaps. We need to think about culturally informed practices that include traditions, acknowledge and value folks' traditions, respect spirituality and spiritual health. That's a big one. Honors and fosters resilience, includes the voices of Black mamas. can you read that? I didn't read that. And then in response to all the needs of all genders, family relationships, there's also that piece, because the typical family structure is not always there. Folks can be supported by their uncles, their cousins, their stepsister, and kind of acknowledging that and working with that. Um, Providing wraparound service and connection to social services is also a big one, because if there are gaps and if we can help to fill them by referring them to allied, we have that at VCU. That's another thing I like about VCU, is that there's a clinic for everything. There's an interpersonal professional, like, cadre that's ready to like take the call, refer the service. It's a good place. We want more women to know. That's why I'm doing this. You know what I mean? Because you just need to hear someone's voice sometime and see someone's face and understand they want to help you. Like, I want to help people who want my help. I'm here. And there's many of us here, but like, it's important that you connect with a provider that you feel safe with, that you can trust, that you can talk to. That's a big deal. And I think that's really an important piece of the culture shift, around the Black maternal health crisis. It's not a new crisis. We're
Right.
just in
No.
this moment where like the lights are on and everyone's looking, but we have to, I think, even more protect our 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 folks that are getting pregnant, because with all this trauma, seeing all this trauma and hearing about this crisis and the potentiality for mortality and morbidity,
Scary.
it's really scary. Yeah,
Yeah.
it's really scary. So even more, we need that support.
Yeah.
So
Well, we
I'm
have a
rambling.
question here from Sylvia. And
Okay.
she says, a question that she has, clients deemed high risk can still look into care with VCU midwives, and it can end up being collaborative care. Like, can you maybe give an
Yeah.
example, like a HIPAA safe example of like a patient who you walked with her through prenatal care and collaborated, like, and she was high risk?
Yeah. I can give a patient that I saw very recently that her BMI is 44. So she's class 3 obesity. And so obesity is a risk factor, right? In giving birth. We know that there are associated outcomes with that. Growing a big baby, gestational diabetes. So basically, this person, due to her obesity, due to her previous birth experience, there were other risks that she brought in from that. She'd had an infection, and things she'd ended up in a C-section, and so she wanted to have a vaginal delivery. This is her second time around, and
So that's another kind of risk category, right? Like
that's
wanting to have
considered
a
a
VBAC.
risk.
Hmm.
Vaginal birth after cesarean, that's a VBAC. And so she wanted a trial. It's called a trial of labor. And so we were able to take this patient. We were able to care for her throughout her pregnancy. She did see the OBs. So that one time, we always have our high risk patients see our OBs, so that we can kind of just, everyone's aware of the patient, aware of that patient's story and their needs, and the OBs, if they have insight or guidance for us, if they feel like we should continue to collaborate, or if they say, hey, no, that patient is fine, you can keep on taking care of them, let us know if you need us. That kind of decision is made after that visit with the OB, and then we continue from there. And that patient stayed in our care for the duration of her pregnancy. We managed her birth, and yeah, I mean, the outcome was a safe and healthy one for her. So I think in another circumstances at another practice, she might not have been eligible for the VBAC. Some practices don't offer that. There are guidelines with that. It depends on a couple of things. She might not, with her obesity, she may not have it with the baby growing so big. There were a lot of things that kind of kept coming up, but because we're nurse practitioners kind of operating in a practice inside a bigger system where we have the resource and the
Yeah, you guys
expertise
have
to
full
oversee.
scope, right?
Yes. Yes, we were able to. She had midwifery care. She had a doula, she had a midwife, and she was able to deliver in a much more, she kept saying that, I can't believe this level of support. Like, I wanted this, but I didn't know if I could get it. And so that's just one example. We have folks that have had preeclampsia in the past, and we look at your history, we read through all of it, we talk about it. We want to protect you. Do you need aspirin in this pregnancy? We need to be looking at your blood pressures. Do you need a home blood pressure cuff? Are there other medications we need to consider? What's going on with your, are you at risk for early birth, for preterm birth? Like, it's a constant evaluation and assessment of risk, but we don't, if you're mostly low risk and if you're eligible for our care, then yes, then we keep you. And so I don't know, I think that the question was saying if you're a high risk patient, bring
Mhm.
your story to us. You know, we're going
Right.
to be honest. The new OB, we have time to kind of dig through all of that and talk about it, talk about the options here. And you will, there's always this shared in decision making. And so, you know, and it's a process. We don't like, it's not like, oh, yes or no. Yeah, for sure or no way. You know, it's kind of like, okay, let me bring this to the team. Let me consult with the doctors. Let's make a decision that centers what you want and what you need, you know.
Right. I love it.
Mhm.
She's
Mhm.
oh, Sylvia says, "Thank you, super helpful answer."
Oh,
Well,
glad.
it's now 6 o'clock, so I don't wanna keep everybody on, but, thank you everyone for joining us tonight. Thank you so much, Hagi. This was great. It was a great conversation. I like chatting with you all the time.
Yeah.
And I think our next one is May 24th. And I think we're talking about group prenatal care at that one, I believe. I'm not sure.
Oh yeah, with Megan.
With
With
Megan Noonan, yeah.
yeah.
And that's another kind of conversation too around how do you take existing programs, existing technologies that you have in the healthcare system and make them more robustly anti-racist, like deliberately, transparently anti-racist, and sort of building it. How do you build those out to be better, and you get better outcomes, and it's better for the provider teams too to not like languish in racial biases. Like that's not okay. So
I mean, we all
um
need training in this time of like woke, you know, it's like this idea that you're like woke on this side and you're not woke on that side, but that's not like we all have bias. Like we all bring things into the way that we see people and experiences. And so this constant, like this intentional dismantling is required
of us all,
of us
absolutely.
all. And so,
Mhm.
you know, this is a time to like, as I was saying about leaning into curiosity, like being able to articulate, like, this is, you know, being able to say, I'm ignorant about this. Like, this is something that I don't know or understand, but I want to help. Like, or what can I do? Or this is how I see it. Is that how you see it? You know, those kind of, I think, that's really important more than ever, you know, because we don't want to be like attacking each other either, you
Right.
know,
I think
we
that's
want to
it.
just be lifting.
Yeah, it is. I think it's, I like your idea about the curiosity, because I think if you come into something with curiosity, you're open, you're more generous with yourself, therefore you're more generous with other people, and you're not kind of coming at it from this like kung fu fighting kind of like, you're always like on the defensive or whatever. Like everybody calm down. We all have to explore this, and it's not going to be easy, but it has to be done. Oh, we have another question. This is from Latalia. I'm 31 weeks, 5 days with twins. The last couple of appointments, I've
Oh,
complained about pelvic pressure and barely can walk. My maternal fetal doctor didn't even acknowledge this, especially when I said it was hard for me to work. I take care of patients. I'm a VCU employee, but I couldn't believe the non reaction. He tells me everything is going well health wise for both the babies and I. Is there a time frame when someone should not be working? I have two other kids, both via C sections.
okay. First of all, congratulations on your twins. I'm a twin mama too. And oh, am I frozen?
Yeah,
Uh-oh,
you just
Kristen, your
froze.
face is not.
But
Could you hear me?
I can hear you.
Okay, your face is frozen for me too. Okay, so I wanted to say that, you know, MFM's maternal fetal medicine, their specialty is really in keeping you, they're watching out, you know, for acute things. They're making sure that you and baby stay safe, stay safe. And like their scope is a little bit different in terms of like, if you're saying you're having some pain, that the MFM is probably thinking that's normal. Are you here?
I'm
Shoot.
here.
Oh my, I don't know what's going on. I'm losing, there you go. So I would, first of all, I'm going to say to you, like, you know, try to wear a belt or like a wrap, a pelvic belt. Those girdles can help a lot, taking that pressure off of the pelvis and putting legs up when you can. There's also pelvic therapy, physical therapy, chiropractic. Those can all be very helpful. I wouldn't say that your MFM doesn't care. I don't know who your MFM is, but I think that it's just they have a different scope in terms of what they're looking for in making you, keeping you pregnant, getting you to term, making sure you have a healthy delivery and outcome. I would try the belt, the chiropractic, and thinking about like ways that you can take pressure off your pelvic girdle, whether that's sitting or legs up the wall at the end of the day. hydrating, all of that. You're welcome to do so. You have prenatal appointments, and you can have your primary, who is the MFM, for reasons that have already been determined. But you're welcome to visit with a midwife for one of your visits. You can ask for us, and we can do a consult. We usually take care of our own patients, but every now and again I will get an OB patient, and I'd be happy to help you or share resources with you. You can also ask your MFM if you can have a referral for physical therapy if you feel like you need it at this time. There's a lot of times there's an emphasis on postpartum because that's when you can really control recovery. The baby's out, because when the baby's still there, you're going to have that continued pressure. And so sometimes, the decision whether to keep working or not, it really depends on the symptoms that you're exhibiting, if you're at risk for preterm birth, if we're able to get you more mobile and comfortable with those simple things, like I said, the girdles, like the wraps around the bottom of the belly, or chiropractic adjustment. But yeah, I would ask your MFM for a referral for within the VCU system, and I would encourage you, if you felt like you wanted to seek out a midwife, and we can do a consult.
That's a great, yep, she says, "Thank you." Yeah, that's a great idea, and I will say too, like, those maternal belts, those maternity belts, it's the game changer. I mean,
It
it's a
helps so much.
game
It helps so.
changer,
If you're on
especially if
your
you're a nurse
feet,
on your feet. Oh,
yes, and I had one. My friends got it for me. It was a whole, like, under the belly, over the chest, and it was
oh,
like
you
more
had the whole
money.
thing.
If they didn't give me, I wouldn't have bought it, but it made such a difference. And I always tell, like, even just African style, with the fabric, a sturdy fabric, that one that doesn't have stretch to it, and you just like put it under your belly, like just above like between your vagina and the top, and between your vagina and belly button, basically, because you're just thinking of like lifting that belly up a little bit, getting like your pelvic girdle just some space and rest. And when you're able to sit, getting those legs up above the hips so that you can bring that blood back down. It's just it's a maintenance thing, because you got two people in there sharing space inside your body,
That's
and
a
it's not
lot of
comfortable.
people.
Yeah, yeah, yeah.
Oh, that's
But
awesome. Well, thank you,
yeah,
Hagi. Thank you, everyone, for all of your great questions, and everybody saying thank you and thank you. This was wonderful. Yes, I agree. This
of
was
course.
awesome. This was really wonderful. Thank you.
Yeah, thank you
And
everyone for being here.
yeah,
Come see us, check us out. And we also do group prenatal care. I know, Kirsten, they're going to talk about that at the next one. Folks
yeah,
need to tune in. That's a whole other wonderful aspect of VCU prenatal support that we offer here.
yeah. It's super
So,
fun.
yeah. All right. Well, take care. Have a good afternoon.
Bye,
Thank you,
everybody. Yeah,
everyone.
enjoy the sun.